everyone. Welcome. Thanks for attending this exclusive special practice management webinar with Fullscript and my friend, Dr. Cheng Ruan. I'm Jeff Glad. I'm the Chief Medical Officer here at Fullscript. I also have an integrative practice in Indiana that I still maintain. And we're excited to have one of our medical advisory board members and what we consider the functional medicine on insurance guru, Dr. Cheng Ruan, with us here today. He's going to educate us on all things insurance and billing that you as an integrative practitioner should know if that's the model of your practice or a model you're considering. And I think he has a pretty compelling reason for you to consider that to be the model you go with. So before we get into the presentation, though, a bit of a reminder, this is, we will be recording this and the slide deck will be sent to everyone who registered at a later time. So if you happen to drop off early or want to watch it again, you'll have access directly from your inbox. We'll also be hosting it live on our website, fullscript.com/webinars, where you can access all of our past and upcoming webinars also. Any questions you have, and Dr. Ruan really wants lots of questions, so he's going to try to pump through the slides, give his core content. We want this to be a rich Q&A, so use the question box in the control panel. I'll come back after the presentation and organize the questions. We'll try to get to all of them if we can, even if we have to go over a little bit. Also, this talk qualifies for CME credit, and Cheng will speak to the specifics to that during the portion of his talk, as you know, I'm sure you have questions about how to go ahead and get that CME credit. But I'll do a little bio here. So Dr. Ruan is a medical doctor, board certified in internal medicine, founder of the Texas Center for Lifestyle Medicine, which is an integrative functional medicine practice that thrives within the insurance system. He's leading the development of an innovative insurance-based functional medicine practice, taking advantage of new CPT codes, and offers training to doctors to practice integrative medicine successfully in this model. He joined our medical advisory board here at Fullscript in 2020. We're thrilled to have him speak here. And I attend a lot of conferences. I listen to a lot of webinars. It's pretty rare to hear something new. A lot of it's reviewed, but I can assure you every time I hang out with or listen to Cheng, whether it's clinical or practice management, I always learn some new stuff. So I'm excited to hand this over to Dr. Ruan, and I'll let you run the presentation. I'll stick around to make sure you've got it up and running, and then I'll bow out until you're done.
Well, Jeff, before you go, we'll put you on the spot here. How long have you been in medical practice?
So I opened my hospital-based practice, which was on insurance, in 2008, and then now I have my own practice since 2010.
Yeah, so so you can tell that there's a lot of issues within the insurance system, right? It's a bit of a headache, right? Yeah.
Well, I couldn't do it, right? Again, like, you know, in 2008, I mean, again, some of the codes are new and weren't available. And now this has become, you know, much easier to do. But at the time, like the hospital, the coders, myself, we couldn't wrap our heads around how to run a model.
I think that at that time, if I was in your position, I probably would have done the same thing and kind of skedaddled. But the people listening here today are going to learn that, man, a lot has changed. So it's going to be a whole lot of fun. And so one of the things that I'm going to get into is really want to be able to focus on the things that really matter. So whenever we talk about like insurance, for example, right? What we want to know is like, why does it even matter in the first place? Like, why are people getting on the webinar talking about insurance? And so it matters is because the people who are listening to this have an interest, right? And that interest is rooted in the fact that we can like deliver a whole ton of value with the public. And what we want to make certain is that not only are we doing it for the right reasons, but we're doing it safely. We're not going outside of any boundaries, breaking any laws or anything like that to do this. And what we're talking about today is even though it's sort of a new and exciting thing, it's still pretty conservative in my opinion, right? And so there's no like hacks or tips or anything like that to somehow miraculously massage more money from the insurance company. That's not what we're here to do. That's not what we're here to do today. What we're going to talk about is structures that's already been designed for optimal improvement, optimal scaling on the integrative health model within medical insurance. most of this really was really starting in 2017, and then 2021 was a huge, massive shift. And then y'all learn in 2023 is going to be even a bigger one. So, and I do say y'all because I'm from Texas, so bear with me if that bothers you. We're going to talk about how to launch and scale integrative medicine within the medical insurance model. And my name is Cheng Ruan. So I'm a board certified internal medicine doc, like Jeff said. And today, if you want to take out your phones and scan this QR code, this section is not CME, but what is CME is that if this applies to you. So this is called a self-reflective CME. A self-reflective CME means that if this applies to you in your daily practice, you can claim it. There's a $5 fee on it. It's provided by Adapt Track. And so if you want to scan that, go ahead. If not, I'm going to continue on with the slides because this slide will pop up again at the very, very end. All right, so let's talk about the outline of what we're going to talk about. We're going to talk about the top billing codes. Well, actually, it's not just billing codes, but billing code categories that integrative practitioners should really know inside and out to start using today to run a successful practice. And what is really required staff-wise to successfully run an integrative medicine practice on insurance as doctors, and I don't like to use the term mid-levels, but someone else made that slide for me, but let's call them nurse practitioners, physician assistants, physician associates, whatever you want to call them, health coaches, nurses. What is coming up in 2023 in billing and reimbursement? This is actually very shocking to me when I learned it, but nevertheless, I will present it. And how does Fullscript optimize the practice of integrative medicine? So if Fullscript didn't do that, I wouldn't be on this webinar with you guys. So thank you for the Fullscript team and Jeff for allowing me to talk about this. So a little bit about my background. I won't bore you too much. So I'm a Texan, but I was born in China. So my grandfather was a doctor in a very small village town, very well-known doctor. Who did Eastern and Western medicine. My grandfather was actually responsible for bringing like the Western medicine into Southeast China, and that's what he's really known for. And so he integrated like Western medicine into Eastern medicine. My mother studied acupuncture and Chinese medicine. Currently, she has a clinic here called TR Acupuncture Herb Clinic here in Houston. My father is one of the dean of pharmacoinformatics at University of Houston Pharmacy School. He's an MD PhD. I did my undergrad at Texas A&M, went to medical school at Ross University School of Medicine, and did my IM residency in Queens, in New York Presbyterian Queens, Weill Cornell Medical College. But I think more interestingly, people want to know what is going on at Texas Center for Lifestyle Medicine. So this was founded in 2017, and it's really focused on basic principles of awesome care. So when I started learning about integrative health, functional medicine, lifestyle medicine, went to a lot of training for that through IFM, ACLM. I find that what was lacking was still the ability for us to collaborate with other docs. And it doesn't matter what style of medicine we practice. I really wanted to collaborate with other docs and see, hey, what else can we do to improve our patient quality of care? And so that's what Texas Center for Lifestyle Medicine was fundamental characteristics, right? But also wanted to integrate mind-body medicine. You know, just my background, I'm actually Buddhist and I'm very spiritual by nature. And so I understand that mind-body medicine has a huge contributing factor to all chronic diseases. And we want to be able to create bridges. Now, let me tell you what that means. So creating bridges is really creating the bridge between not just us and the patient, but us and the insurance companies, and then between the patients and the insurance companies, and then between the patients and their family members, and between us and the family members. So we have these four bridges that we really like to focus on in engineering the quality care that I see where we can go in the next few years in all the United States. And also mutual respect through communication. And so mutual respect is absolutely important, but the way that we communicate, especially in the medical field, may be very short and brash. So there's definitely a new level of communication that needs to be designed when we practice medicine. And then the fundamental characteristic, of course, is creating systems within insurance systems, and there's no compromise in quality of care. So that last one was a big question mark for me back in 2017. I really didn't know how I was going to do it per se, but I knew some numbers and I knew what the fundamental principles were. And let me tell you, the last 5 years has been the biggest roller coasters of my life. So let's talk about what the care model is for us at Texas Center for Lifestyle Medicine. So we have health coaches and allied health professionals. When I say that we're centered on health coaching, I really mean it. I mean that I see our practice really as a coaching practice. And then our allied health professionals, our doctors, administrators really surround the concept of coaching. And this was really this didn't really start that way, but I'll talk about later how it even morphed into that philosophy. And we're very goal oriented. You know, we're not just guideline oriented. Yes, there's guidelines for American Heart Association, there's guidelines for American Diabetic Association. We're beyond guidelines here, and our goals actually focus on what the patient's goals are. And we work with in-network insurance contracts. Also Medicare, TRICARE, and some other government programs, Medicaid programs as well, private insurances. And we also conduct group and individual visits, both on telemedicine as well as in person. But we are very telemedicine heavy since the global pandemic. Not surprising there. We really have to make that giant pivot to really survive. So here's some benefits of insurance, right? You got great access to patients. Patients have access to the excellent care that we can provide. There's a low customer or patient acquisition cost. So for those of you who are business literate, a CAC is very important. Customer acquisition costs is what makes and breaks a company. And in medical practice, taking insurance, a lot of times get automatically assigned patients, which actually dramatically cut down costs. That's what I was talking about here. And there's a higher perceived value of services because if the patient says, hey, I can use my insurance fully or partly for something, they would definitely want to do so. And so here's the big vision, right? And here's the ultimate goal. I don't think, for me, whether we call it integrative health, functional medicine, lifestyle medicine, I think ultimately there really shouldn't be a label in medicine. It's just practicing good medicine, right? And I think that there's predefined roles for clinicians that are set, and the roles for clinicians are set as guides and not necessarily heroes. And we have to be able to let the patients be their heroes. And that should be predefined from the get-go and maybe aware from the get-go. And that's exactly what we do really well in our practice. And we like to collaborate no matter what, right? And no matter when, I should say. Some people aren't necessarily ready to take that step. We want to be able to collaborate with the patients, the family members, their doctors. And sometimes the patients are ready, but their doctors aren't. Sometimes the doctors are gung-ho about it, the patients aren't, but we want to be able to ultimately have a form of collaboration. We want to always be persistently learning from colleagues and other clinicians, no matter what their belief systems or structures are, because most of the time, our colleagues and clinicians have a golden heart, really wants to help our patients. Want to be able to create a fellowship of professionals that speak the same language. So I can't tell you how many times when we have referring providers, when other doctors refer out to, all it takes is some text communication sometimes, secure messaging, emails to collaborate on a patient, that we can all deliver the same language to the patient and to each other. So we're always sort of cultivating the patient on the success path. And for those of you doctors who are practicing or health coaches or dietitians and anyone else on this call, you kind of know what it means when one provider says one thing, another provider says something else. Ultimately, everyone really has to communicate together. We want to be able to cultivate patient care delivery models through something called shared medical visits, group visits. That is huge, and I think it's actually necessary to survive within the insurance model, but it's also necessary to scale within the insurance model as well. And this is a big one. This next bullet is probably my favorite bullet on this whole thing, is collect PRO data, patient reported outcome metrics. Collect them, collect them, collect them. We use a company called Outcome MD to do it, which actually helps the patient text us their questionnaire so we can track them over time and make pretty graphs. And so outcome metrics are so important for many reasons. And if y'all follow me on LinkedIn, I just made this post on my new newsletter called Rebuilding Healthcare, is that collecting outcome metrics makes certain that we know what we're doing is working, And we also know that what we're doing is something that we want to continue to do. I can't tell you how many times where I thought something was a great freaking idea and we collected the outcomes. We're like, no, this is not even beating the national standard. So we either scrap it or turn it into something. So this is a perpetual learning process through patient reported outcomes. And we're 5 years into the practice, and guess what? We're still collecting it on a daily basis. Sometimes it drives my staff nuts, but that's what we do. We don't want to create any resentment between integrative health practitioners and other doctors. And for those of you listening, you might have seen this really on social media over the last couple of years. There's a lot of resentment that gets created, but there's no, it's completely unnecessary. And the insurance is not a hindrance to the care delivery model. It is something that is very useful. And hopefully by the end of this presentation, I'm going to convince you that's the actual case. Some people were like, no, you're not, but we'll see. So this brings me to the convincing part, which is called billing opportunities. Okay, 2021, big changes. This is something that I put hours into understanding why they did the changes and what the changes are. So 2021 revisions to the E&M codes. And Jeff was practicing, Dr. Glad was practicing and had to make some pivots back in 2008. Well, if he had this in 2008, then he probably would have thought otherwise. So billing and coding and documentation became easier and far more flexible. This lifts physicians and care teams from a lot of time-wasting administrative tasks that are clinically irrelevant. So for those of you doctors who are listening, you probably know what the review of systems are. It's sort of something that we always dreaded in medical school and residency because we think it's a waste of time. And so that portion was no longer exists as a billing criteria in 2021, and we're all very happy about that. That will be an example of a time-wasting administrative task that's not clinically relevant. And there's also new modifications to E&M codes extended to inpatient observation care services, consultations, ER departments, nursing facilities, home and resident services, and prolonged service visits. This is really important because a lot of what we're going to talk about, even though it's an outpatient office visit, if those of you who are emergency docs, consultative docs, who do also do geriatrics, home and resident services, all this applies to you as well, which is really exciting. So this is what I want to point out. This is quoted by This is a quote from President Jack Resnick Jr. The process of coding documentation, almost all E&M service, is now simpler and more flexible. We want to ensure that physicians and other users get the full benefit of the administrative relief from the E&M revisions. The American Medical Association is helping physicians and healthcare organizations prepare for these E&M changes and offers resources to anticipate the operational, infrastructural, administrative workflow adjustments that result from the pending transition. Long story short, summarizing this slide, they made resources. If you go to the AMA website, the American Medical Association website, they even have online courses. They have CMEs that actually talk about the coding and the updates, and they're releasing now new ones for 2023. Which is going to be finalized in the end of November. Very exciting times. All right, so real quick, I'm not going to go into the details of this. Long story short, we have these things called E&M codes, and E&M codes used to be very complex. We had to meet a certain number of diagnoses or a certain number of review systems, a certain number of physical exam elements. So it really turned the task of documentation into something that every doctor dreads. And so whenever they change this based on physician billing and allied health professional billing, they started using one specific criteria called MDMs, or medical decision making. So now they've changed to different categories of medical decision making. So for example, really good example is, let's say you're working with a patient and this patient can't consent or make decisions on his or her own. That happens a lot with our Alzheimer's patients. And if you're getting the historian from one or multiple family members, that increases your level of complexity. Well, this is cool. Talking to family actually increases level of complexity, which means you can bill a higher code. Yeah, that's one of the things, you know. Or if you look at Have anyone ever looked at a lab test and analyzed it yourself and interpret yourself, or looked at a piece of imaging like a CAT scan or X-ray or ultrasound and interpret yourself? That's also a higher level of decision making. So when Dr. Glad practiced before 2000, back in 2008, none of this was available. This is really available in 2021, where a lot of the complexities that actually reflect the things that we do, especially integrative health, automatically qualify for a higher level of complexity, which is phenomenal. And time. Now this is great because there's now time ranges that you spend that qualify uh, for billing reimbursement, and the more time that you spend, the more you get. Well, wasn't that true before in the past? And the answer is no. Before in the past, before 2021, the time that you spent only with the patient is what you get reimbursed for. But now you get the time with the patient plus the time documenting. And if you're looking up a guideline or looking up specific things for the patient, you're utilizing that research for the actual patient, for patient care. That time is bundled into here as well. So any time that you're utilizing for yourself to engage with the patient, plus not engaging with the patient, but time outside of it on the same date of service, all that time gets compiled into here. And so for integrated health practitioners, I mean, we document everything. We document who they live with, how much money they got, their social determinants of health, their mentality, their joy in life, different questionnaires. So all this time documenting, collecting the data actually goes into the time criteria as well. So we get to pick between billing by time versus billing by medical decision making, as in the previous slide. And so, once again, this is designed to give an overview. You can read about this on the American Medical Association CPT panel site. They go into very big details and even have multiple examples of this as well. Okay, this is the 4 categories that no one is doing very well or at all. So, is billing for things outside of a patient visit. For example, did you know you can bill for a text message to the patient or their family member? You can bill for them sending you a picture of something, whether it's something medical or maybe they're logging their food journal. You can bill for a phone call, right? Five or more minutes of phone call, and even if you have a longer phone call, there's different codes that correlate with that as well. So any type of communication with the patients or their caregivers or their doctors are things that are billable. So I have time set aside in my day specifically trying to coordinate care with the patient's other doctors. So I can call their primary care, I can call their cardiologist, I can call their neurologist. And this is without the patient present, and that's called interprofessional consultation billing as well. And so that's something new that no one I know is really doing very well, but it should be done. You can bill for behavioral change discussions. I mean, with integrative health docs, I mean, we're all about the behavioral change, right? And so that behavioral change, even if it's done virtually or through email, these are things that are actually billable, right? These were not done before or were not available before. You can bill for researching for patients and even the chart review. There's actually chart review CPT codes that are actually reimbursable as well. So if you ever get a patient with a gigantic chart that's slept on your desk and you have to go through it, you can actually bill for that even if it's not on the same date of service you see the patient. So we do something called chart prep. So the day before, sometimes the week before, if it's a really complex case, we have a team chart review with the patient. And so before, that can't be done. It can't be a business model. But now it is, because there's actually reimbursement opportunities for reviewing these cases. So naturally, we all get together as a team, like a multi-faceted team, to discuss the patients. Like, my doctors, my coaches, outside doctors, et cetera, et cetera. So any sort of collaboration is actually very well promoted. But very few people are taking advantage of these because that's not how the medical system was built to do previously. So phone calls, patients love phone calls, and we love billing insurance for them. And insurance love reimbursing for them because, one, it saves them money. But two, it decreases patients' patient visits to the ER and to the hospital. 3, it decreases days of hospitalization. So we know that touch points and phone calls actually decrease the cost of healthcare. Now, when the AMA CPT panel, in collaboration with MGMA, um, created these communication codes in 2017, they were very disappointed because people weren't really utilizing them. And they're like, are people not calling their patients? It's quite the opposite. Most docs I know aren't just not billing for them because they just don't know about them. It's too new. And you know what? And what's great about this, especially working in my field, which is the brain, and doing care coordination with the family members and dementia patients, a lot of times it takes a lot of phone calls on different days sometimes to just get something done. But believe it or not, these little things, these few-minute phone calls actually add up big time for reimbursement. And I will tell you that oftentimes the way that we structure our days with the phone calls, it can it can reimburse just as high, if not more, than the actual patient visit per minute. So think about that for a second. This is a super busy slide, but it's tended to be because I want to tell you that this is what we use for our billing sheets in Texas Center for Lifestyle Medicine. And so I'm not going to ask you to remember anything, but really simply, this is a slide that shows digital communication codes. So we have this happy face in the top. I want to communicate with a practice. Is it a phone call? Is it a message? And then there's different codes that correspond with physician versus a non-physician qualified healthcare professional, such as NP or PA. And then for Center for Medicare and Medicaid Services, there's these G codes, and that correlate with like picture or video and virtual check-ins. So this is not designed for you to obviously remember. This is something that is a part of the digital communication process and what the flow sheet that actually made at Texas Center for Lifestyle Medicine. This one, once again, don't have to remember it. I'm sure a lot of people are taking phone images of this, but don't worry, you're going to get the slides after this, so don't worry about that. So this one is looking at how to communicate with a consultant. So you have a treating doctor and then you have a consultant. You see how the consultant can bill by time, and the billing doctor and the treating doctor can also bill by time. And the consultant can actually get reimbursed for 5 minutes or greater of writing a written report to the treating physician. This is huge. When I started telling the specialist this that we refer to, you know how many phone calls and how many emails and how many written reports we automatically got just based on that? It improved patient healthcare, improved communication between all the practices that we work with. Doesn't matter if it's a bariatric surgeon versus the ENT versus pediatric versus psychiatry. I do educate a lot of our referring physicians that this should be built out. Please do this. And so if you do this, you'll understand that the effort and you put into collaborative medicine, practicing collaborative medicine is very well rewarded as well. And this last category is my favorite. It's behavioral assessment. And so this is a category where there's a series of different codes. Now, not everyone can bill for this. Depending on what part of the country you are, it's specialty dependent. In some areas of the country is only psychologists, but if you're in Texas, like me, for most plans, it can be billed by all specialties. So this one is great because it talks about health behavioral assessment or reassessment, and it's non-time based. So we do a lot of health behavioral assessment, especially with outcome data tracking. And so if a patient is doing well or not doing well, we get the data and we analyze the data and we create a plan from the data, even with the patient not physically there. If we're getting this data from home. These assessments can be built out, and then you can do something about that. So what do you do about it? Well, you can have one-on-one visits with the patients, or you have group or shared medical visits with the patients. And so the people get shy a little away from group or shared medical visits because there's no official training to do that. Outside of psychiatry and outside of allied health professionals and dietitians, for most MDs, there's not a training that actually will support group or shared medical visits. So, but patients have been seen in groups for over 30 years in primary care. The American Academy of Family Practice, I mean, they put out a guide in 1997 to encourage more family practice doctors to start group visits, and that guide is still on the internet. It's one of the most referred to guides there, and there's tons of just blogs and guides by national bodies to suggest the use of E&M codes within these group visits. So just like the regular one-on-one doctor visit codes, you can use the same codes within the group sessions. That's exactly what we do. So we do that mostly virtually and some in groups, but it really depends on the scenario. And then there's non-face-to-face billing. Basically, if you're doing a chart review, if you're working with a patient and they're not physically there, researching about their disease states and allowing and documenting that process. There's a non-face-to-face time code called 99358. If you take longer, it's 99359 as well. Oops. So other reimbursement areas are chronic care management, remote patient monitoring, principal care management, and remote therapeutic monitoring, which is new for 2022. I'm not going to dive deep into this, but that's why I created an online academy called Integrative Practice Builder at integrativepracticebuilder.com. And I dive deep and heavy into each aspect of this and the billing and coordination of care for each of these models as well as all the models that I included before. Okay, so I know I'm boring you with codes, but this is the last slide on that. So what's new for 2023 is that AI gets its own taxonomy. Literally, artificial intelligence gets its own taxonomy. If y'all don't know what a taxonomy is, it's basically a specialty. It's a specialty that's created, and people can exist under taxonomy. For example, for me, I'm an internal medicine doctor, so I have an internal medicine taxonomy. For health coaches, there's a health coach taxonomy that was created in 2021. And now AI has its own taxonomy. And there's more extended visit reimbursement. If you need to take longer with your patients, hallelujah, great. You get reimbursed for it, and that reimbursed at even a higher rate than it did ever before. There's also reimbursements for social determinants of health data. Whoa, which means that if you ask the patient about how they're living, what their struggles are on a daily basis, where do they live, do they have access to food, quality food, do they have access to healthcare? That's billed at a much higher complexity rate. So anytime you're talking about the social determinants of health and collecting it, that qualifies for higher reimbursement. That's new for 2023, really exciting. And there's new VR reimbursement codes as well. Now, we don't know too much about this. We know they exist. They actually have some temporary codes right now, but they're going to announce everything in either November or early December, and we'll get a little more taste on what the virtual reality reimbursement codes are. Virtual reality is really the wave of the future. People are accessing virtual reality for cognitive behavioral therapy and whatnot, which brings me to the very next code. There's a new code to report cognitive behavioral therapy monitoring. So if someone is getting cognitive behavioral therapy and you have some way of monitoring them, either a health coach checks in on them or either you have an automated AI process with an app, there's a reimbursement code for it. And so that is really exciting for us because we do a lot of mind-body medicine within our practice. And the new codes to reimburse for digital therapeutics. Now, this is probably the most exciting of all of the 6 bullets here. Digital therapeutics means that people can make digital products for improvement in healthcare, whether it's behavioral change or whether it's psychological issues, or whether it's neurology. There's ways to get reimbursed for digital therapeutics as well. So this is a huge, massive step in the right direction and a very exciting time to practice integrative health. All right, so no more codes, I promise. So now, the teamwork makes the dream work. We all know that, but let's talk about who makes up the care model, the collaborative care model in the practice. So obviously patients and their families. Health coaches are the core and the crux of what we do. Without health coaches, we cannot do a lot of things that we do. In fact, health coaches elevate physicians and other allied health professionals within the organization much higher. So we can focus on the things that we are really, really good at, and the health coach can focus on things that they're really good at, which is behavioral change. So we have functional medicine health coaches, mind body medicine as well. We have dietitians, physicians, allied health professionals, medical assistants, and then patient success admin team. So I like to call them patient success admin team because that's exactly what we try to provide. We build bridges no matter what with the patients, doesn't matter what they say. We try to reach out to them and make communication as clear as possible and make sure that they're successful. And the last piece of the collaborative care model that a lot of people don't like to be involved in their team is the billing and coding team. Is because it's a big black box for a lot of clinicians. But without the billing and coding team, we cannot exist. We cannot do anything without the actual numbers. So I would like to know, hey, how are we doing in this particular CPT code? United Healthcare versus Blue Cross Blue Shield versus Medicare. What are they saying? What are rules that we have to write to make sure that we're building the right codes out? These are things that are basically, it's the basics and fundamentals of business in the medical business. And if you're a physician and you're like, you know what, my billing team will take care of it, well, there's a big surprise there. That's not necessarily true for the most part. I've talked to a lot of billing company, consultation companies. There's a big gap between where the doctors want to go in terms of the practice and billing and coding. So that's another thing that I teach on the Integrative Practice Builder. So we recently partnered with Heal Community, and this is a fantastic company. You can scan the QR code to check them out if you want to, because we were doing so well with health coaching that now there's a huge backlog. So I called my buddy James Maskell, who's the founder of Heal Community, and I'm like, hey, listen, we need some help. And then he threw up these statistics for me, and he's like, hey, you know what? We just published these. We have an entire health coaching patient outcome data that shows there's 68.6 reduction in pain, improve cognition by cognitive function by 90%, physical health increased by 95.7%, et cetera, et cetera. So I'm like, wow, this is amazing data. This actually definitely beats the standard of care. And consider this is actually data was collected during the apex of the global pandemic, which we know significantly increased anxiety, significant depleted sleep, significant worsening pain, significant increase the diagnosis of Alzheimer's dementia by 60%. But look at this coaching community, they're increasing cognitive function by 60%, turning it around. So this data is absolutely shocking, even in a normal situation, but for them to get this data within the pandemic was actually very impressive. So good job to you, Heal Community. And so the whole idea is to have patient satisfaction outcomes and scalable and profitable organizations. So if you're a clinic and you consider health coaching, and if you find that hiring a home health coach or getting more health coaches is really daunting task, hit these guys up. They're going to make things a lot easier for your life. Once again, the QR code is at the bottom left, and it's Heal Community. So, and then this is an integrative practice builder. That's my company. So build, scale, ignite your insurance-based integrative health practice. So for the little surprise for the webinar here, so if you enter the code Fullscript, you get a surprise discount. It is a humongous discount, so not a small discount whatsoever. So go ahead and scan the QR code, and I'll take you to the site and enter the code Fullscript on checkout. And also, this whole entire integrative practice builder also has continuing medical education credits. That's sponsored by the company that sponsors the webinar today, which is AdaptTrack. So in the community, we have applying health coaching to insurance-based clinics, how to leverage shared medical visits, group visits. We have MBA-ish, basically principles not taught in med school. Master the revenue. This is all about revenue cycle and the basics of business and scaling. Operations. This is my favorite section. You can't do anything without operational fluidity. Cloning yourself. This is more hacking yourself to get more things done, and leadership qualities as well. So this is the integrative practice builder. So go ahead and check that out. And once again, the coupon code is Fullscript. And so I'm going to bring Dr. Glad back, I think, for this section. So Jeff, you can unmute yourself.
Yep, let me get there.
Oh.
Good job, man. Am I back?
Yeah, you're back. You're back. So what I want to talk to you today about is really about Fullscript, obviously. And in this slide, I like to have an interaction with you. So one of the great things about Fullscript is that I like technology that makes my life easier and that makes my team's job easier and the patient's life easier. So anything to improve the ease of use is exceptional. And we know these days everyone's comparing how easy it is to like an Amazon or an Apple or something that is very noticeable and that's marketed very well. So Fullscript actually has a significantly easier user interface than a lot of other interfaces. But more importantly, we want to make it easier for the patients to return to the platform and so engage to the platform. So and creating incentives to return to the platform because this actually improves behavior as well. So Jeff, one of my favorite things is making protocols on the platform and actually delivering to the patients. They letting them know exactly what it is and attaching PDFs to it. And so most people see it as a supplement platform. I see it as an operational must, right? And so that's why I'm excited to get onto the platform today. But yeah, Jeff, I just want to have you kind of take it away on this section.
Yeah, I mean that our job is to move away from just being supplement dispensing and become a treatment planning tool, right? Just what you alluded to, right? So that treatment planning tool, which allows you to quickly go make integrative medicine easier to practice and deliver with your protocols, with your resources, and then help with the the adherence of your patients to their plan, right? It's education, it's keeping the plan simple. I think one of the biggest boosts right now that we're launching in I think 25% of accounts got this, and it's going to grow, is auto refill, right? So let your patients know at a discount you now can just subscribe to your treatment plan. And one of the big reasons for skipping a month, skipping 6 weeks, even 6 months is not being able to get back to the clinic, not being able to find back, get back on Fullscript. So the auto ship and auto renewal has been a big addition already. And as we grow that all to the other accounts, it's part of that keeping your patients on their plan and one less thing for you to worry about in your clinic, managing inventory, making sure you've got the stock when they come back.
Jeff, I'm going to give you a little surprise here, and this is the reason I'm having you speaking on this, is that we actually utilize Fullscript to know what to bill insurance companies for. So you want to know how we do that?
Yes, sir.
So, so this is something that I want everyone to understand. The the a lot of the CPT codes were created for us to track patients over time. And a lot of them were to ensure compliance. I don't like using that word, but that's what they call it. Compliance to medications, compliance to proposed dietary changes and lifestyles, right? But there's also compliance to protocols and supplements as well. That's just as important for these people. And so the whole reason why the remote therapeutic monitoring codes were created for 2022 is to document compliance. So a lot of the interactions between patients and us through Fullscript and messaging and stuff like that, yes, we're actually tracking their compliance because do they ask us about supplements to take? Yes. Do they ask us about medications and other regimen on the platform? They actually do. So it's a great thing for us to track if patients have opened their shopping cart. If not, we reach out and we make sure that they're compliant with the actual regimen, and we make sure that people are all actually on track. So people are very surprised when we say, hey, you know what? I saw that you actually logged in at this time but didn't get anything. Is there something that we can do to really help you? And then we realize they actually have a whole other level of medical issues that we haven't really addressed that really allows us to create a much bigger conversation with the patient many times is decrease hospitalizations, decrease ER visits and urgent care visits. Really saves the insurance companies a lot of money. And so, but that's one of the ways that we utilize Fullscript is with tracking compliance communication through remote therapeutic monitoring.
Beautiful, beautiful, beautiful. Awesome. Dude, thanks. That was incredible, as always. Again, lots and lots of information. So we got about 13 minutes here. So let's knock out as many questions as we can. So I'll tee them up for you and you answer. So this question is, though you can code for these and bill many, though you can code for these and bill, many insurances are not paying for the additional codes outside of E&M, such as the communication codes, interprofessional collaboration, et cetera. Which insurances are you using in your practice that are paying for these codes?
Really good question. That's actually my favorite question. I'm so glad we addressed it in the very beginning. So some insurances don't even have these codes on their fee schedule. But if you ask them, what do I do about it? Because let's say you're talking to, like one of our plans that we talk to is a government and marketplace Medicaid backed based insurance called Ambetter. We're like, hey, you know what? I'm trying to bill for our telephone conversation, and there's these CPT codes that exist. It's not part of your fee schedule. Like, what's up with that? Like, what do I do? How can I be reimbursed for this where other insurances actually paying me these codes, but you guys aren't? You know what they told us? Like, oh yeah, easy. Just go ahead and bill out the E&M codes for the phone calls. And so I'm like, oh, well, that's actually better reimbursement than we would have done. So most people don't have that conversation with the insurance companies, right? So here's the thing: insurance companies' job is to not pay you. It's not to just like, hey, we're like, wow, we're not going to pay you. Their job is to let us practice medicine, and our job is to question them that these things exist. Phone call codes exist, right? And so why can we not bill for them? And they'll surprisingly, very surprisingly, they'll always come up with a better solution than you've ever had, right? We did the same thing with United Healthcare plans. We did the same thing with another contract that's government funded in the state of Texas only, right? And so these are the things to really ask and understand what's being reimbursed. If you don't ask, you're never going to get it. And guess what? The worst thing they can say is, no, we're not going to get reimbursed. But I will tell you that most of the time, they actually find solutions for us. So super important point here.
Yeah, awesome, good. There's a couple questions that speak to this. So I'm going to take the one that sort of encompasses the other questions that are similar. If you bill insurance for a phone call, text, consultation, et cetera, and the insurance leaves it to the patient to pay for, hitting their deductible or co-insurance, do you still collect from your patients directly? And how do you make patients aware of this bill before they get it?
Well, first of all, this is operations. This is not billing, which means that from an operations side, patients have to understand what you do as a practice. So our messaging is that, hey, you know what? We would love to make phone calls and set up phone calls for you at this time, even if you want to talk about vitamin D, whatever it is, right? And we're only able to create this structure because we actually have an insurance benefit that allows for this, and this is the code for it. So we literally give patients code if they want to look it up. So patients will either talk to the insurance companies, yeah, we actually bill for this. And I can't tell you how many times they appreciate like the actual phone calls. They're like, I don't care, just bill my insurance. Like, I want to have a phone call with you. I don't want to come to the office. I don't want to sit down for telemedicine. I just want to have a phone call with you, right? And so those things should be within your billing policy and financial policy within your practice. But it's not good enough for it to just be a policy. You have to communicate to the patients. So if it does hit the patient deductible, they have to know about it. And the other thing that we do is we pre-verify every CPT and E&M code, which means that we go to the insurance company, their specific one, and we have a list of things to pre-verify for the insurance. We actually have an ongoing chart in the top right that shows me what codes they actually can qualify for and shows me what they don't. And if they don't qualify for this, what is the alternative billing code for it? And so that's as granular as we get, but that's what's required in the practice of medicine and business medicine. Great question.
Perfect. Do you or anyone in your group have practical experience with sub-billing for naturopathic physicians as part of the practice in states where the licensure is not yet established?
Oh, that's like Texas. Fortunately not. I don't have that. I'm looking into it, but I'm not knowledgeable to speak about naturopathic physicians.
How do you find the right people to talk to at the insurance company? So you keep saying you talk to the insurance company. How about some quick tips on how do you find that right person?
Okay, so these are great questions, and it's stuff I wish I knew years ago. So step one, when you contract with an insurance company, you usually have representative and agents. Okay, now contacting them is a whole other ordeal, right? But you gotta be relentless about it. And so that's really step one. And then you have to contact from different angles. So for example, you have United Healthcare has a different department for mental health billing versus physical health billing, medical billing, right? So you have to talk to the right departments there. So it takes some effort to get into. Now, I don't find who it is. My administrators do, and they're really good at it because we're really relentless. The second thing is we're part of an accountable care organization, one of the largest in the country, called MHMD, Memorial Hermann Medical Network. And so our ACO actually fights for us and have representatives within the insurance companies as well. So we're able to tap into that as well. So if you're independent practice, well, that's outside of an ACO or IPA, which is the Independent Physician Association, or IPO is Independent Physician Organization. If you're outside of that, it's a little bit tough to do. But if you, about 78%, I think, practices are actually within the organization that reach out to your ACO representative, organization representative. They're more than happy to combat for you as well. And then the last thing is that most of the insurance companies with the local chapters, their emails and stuff are actually published within your contract. So dig out your actual insurance contract to see who to talk to. And then if they don't have the actual email, they actually have the platform, the URL to engage in this communication process. Since the pandemic, honestly, a lot of these insurance turned into online web chats. They really did. And I'm so happy about that because phone calls are really annoying. But be relentless in looking for that. And then, always have someone on speed dial. Yeah.
Awesome. This one I've got the answer to because I know them as well. So what was the name of the company for PRO, or patient recorded outcome data monitoring? And that's Outcome MD, right? That's who you use in your practice.
Outcome MD. Great organization. Mm-hmm.
Perfect. So there's three questions. Sort of the theme here is, are there any codes that health coaches or other non-physicians can bill for, or do they always require an overseeing physician? So, health coach that's independent, is there an insurance reimbursement model for them?
Yes and no. So health coaches obtain their own temporary CPT codes, and I'm actually part of the coalition that's fighting for it to be not temporary. That's a battle that I think we're gonna win. But can't tell you when, but eventually it's gonna happen. So these temporary codes can be reimbursed not by specific insurance companies, but by self-insured organizations. So for example, we have a company here in Texas. Have you ever heard of them? It's called Chevron. They actually have health coaching reimbursement through some policies for programs as part of a bundle package, right? And so that could be independently billed within that organization. But most of the major carriers, Medicare, Medicaid, you're not really going to be able to find reimbursement on that. And I hope that changes very, very soon. So those are the temporary health coaching codes. So the answer to the very first question is, do they have to be under supervisory physician? The answer is yes. So far, yes. Mm-hmm.
Got it. I've got a good one that I know is really a passion for you right now. But real quick before we get to that one, and I know you can answer this quickly too because you blew my mind when you had the answer. But so all these new CPT codes, are these just sort of COVID pandemic related and are likely to expire, so that if I move my practice to them, they're going to pull the rug out, or are they permanent? So I know you've got the right answer for that one.
So these codes were created before the pandemic. All the pandemic did is to fast forward the AMA by 6 years. And it's like, oh yeah, we've been doing this. We've wanted to launch this since 2016. You know, if you actually look at the AMA webinar of the docs that were on the panel that talk about these codes, they're actually pretty happy about it because they're like, yeah, we've been planning this for 5 years or whatever, right? 4 years, and then the digital communication codes came out in 2017, and that's well before COVID, right? The 2021 E&M changes that was proposed back in 2016. You have the interprofessional counseling codes that came out before the pandemic as well. I forgot what year. So most of what I talked about actually came out before the pandemic, but it's not going away anytime soon. And in fact, there's a huge push for more doctors to utilize these technology-based codes because they're tracking how many people are using it to figure out how valuable it is. So I wish the whole country would start using them.
Awesome. All right, we got time for one more. And again, like I said, I know this is a big passion for you right now. Yeah. So do you participate in meaningful use and other value-based programs? But the question that I really am interested in hearing you answer is, and as such, how do you handle the quality indicators? For example, the number of people on a statin when you may be using nutraceuticals or lifestyle to manage lipids. Is this measured through your PRO company, right? This is proving your outcomes, proving your, taking a different path in caring for your patients.
I think there's 2 points to that, right? Is there a value-based contract that we're using? We're using partial value-based contract, the MSSP for Medicare through our ACO. So Medicare shared savings. So we get bonuses based on the value there, right? And the second part is, if we're using nutraceuticals and collecting data on that, are you demonstrating the value based on that? The answer is absolutely yes. Like, especially if you use nutraceuticals, if you use supplements, if you use anything like that, you have to prove the things that you're doing are actually working within your own practice. There's 2 reasons why. One is the more obvious reason is you always want to know that whatever you're doing is working, right? So if what you're doing is not working, you always want to be able to pivot in favor of the patient. 2 is you want to document the things that you're tracking as well. So for example, in the state of Texas, if you were to go under the medical board for any issue, they actually look at your reputation, they look at your documentation, if there are any clinical improvement projects. So for the ethics part, for the ethical behavior part of you as a physician or you as an organization, that is a big check mark that actually helps you before any medical boards as well. So it's really a risk reduction thing as well. And so I think everyone should be tracking outcomes regardless of what they're doing, whether it's nutraceuticals, diet, pharmaceuticals, stuff like that. It's really important.
Super. Cheng, thanks a ton for the great presentation. Thanks for the content and hanging out and giving up an evening to be with us. So once again, to everybody following, quick reminder, you will receive a copy of this recording in your inbox and the slide deck. So your resources will be right there. Your codes will all be right there. You didn't have to memorize any tonight. And all of our webinars, past webinars, current webinars, future webinars, fullscript.com/webinars. Everyone, thanks for your attention. Thanks for joining and hope to see you next time.